Hello everyone, my name is Guillermo Rodriguez. I'm a second-year internal medicine resident at Amita Health St. Francis Hospital in Evanston. I want to thank the American College of Physicians, Illinois chapter, for allowing me to present our work. Today, on behalf of my team, I will present our abstract entitled Remembering the Spanish Flu, Coinfection of SARS-CoV-2 and Streptococcus pneumoniae, a case series. Since December 2019, SARS-CoV-2 had caused over 8 million cases of COVID-19 and more than 200,000 deaths in the US. As the pandemic evolves, the scientific and medical community accumulates more evidence of the disease's clinical characteristics. However, information regarding bacterial coinfections is still minimal and sometimes overlooked. Between 1918 and 1919, the Spanish influenza pandemic caused around 50 million deaths worldwide. Preserved lung tissue sections and autopsy analysis have shown that most of these deaths likely resulted directly from secondary bacterial pneumonia by common upper respiratory tract bacteria, with Streptococcus pneumoniae playing a significant role. This lethal synergism between the influenza virus and Streptococcus pneumoniae is not limited to pandemic strains. During the seasonal influenza period, up to 41% of bacterial co-infections are attributed to Streptococcus pneumoniae. In contrast, bacterial co-infection is considered relatively infrequent in hospitalized patients with COVID-19, and the co-prevalence of Streptococcus pneumoniae is even lower. We present a case series of 11 patients with co-infection of SARS-CoV-2 and Streptococcus pneumoniae. We retrospectively analyzed clinical characteristics and outcomes of the patients subsequently admitted to Amita Health St. Francis Hospital between March 1st and June 30, 2020, with confirmed SARS-CoV-2 infection by real-time PCR or isothermal nucleic acid amplification performed on nasopharyngeal throat swab specimens, and documented Streptococcus pneumoniae infection defined as positive blood or sputum cultures or positive urinary antigen. We identified 11 patients with Streptococcus pneumoniae co-infection, 9 patients with positive urine antigen, 1 patient with positive blood cultures, and 1 patient with positive sputum cultures. Most patients in this series presented with acute distress, namely fever and shortness of breath, had elevated inflammatory markers, showed unilateral bilateral infiltrates in chest x-rays, and required some sort of oxygen support. The mortality rate among this group was very high, 74.5 deaths per 1,000 patient days, which means that if we will follow 1,000 patients with SARS-CoV-2 and Streptococcus pneumoniae co-infection daily, almost 75 will die each day. Bacterial co-infection is considered uncommon in patients with COVID-19 who are newly admitted to the hospital. A meta-analysis of 30 studies that included 3,800 patients found that 7% of hospitalized patients with COVID-19 had a bacterial co-infection, increasing to 14% in studies that only included ICU patients, with little evidence of Streptococcus pneumoniae having a significant role. Despite the low frequency of co-infections reported in patients with COVID-19, they are associated with poor outcomes. Up to 50% of patients who have died of COVID-19 had secondary bacterial infections. At our center, 11 patients with COVID-19 pneumonia who had confirmed infection with SARS-CoV-2 were diagnosed with Streptococcus pneumoniae infection while in the hospital. All patients had pneumonia confirmed on imaging and a non-specific increase in markers of inflammation. The in-hospital mortality rate was very high, higher in this group than in previous reports. This study highlights the importance of monitoring bacterial co-infection in patients with viral lung infection due to SARS-CoV-2. Thank you for your attention. Have a nice day.